webinar, The Power of Patient Perspectives. I'm Stephanie Adler-Yuan, Director of Education and Training at the Schwartz Center for Compassionate Healthcare, and your moderator for today's session. As you might know, the Schwartz Center for Compassionate Healthcare is a national leader in the movement to make compassion a vital element in every patient-caregiver interaction. We're so glad you've joined us today, but before we get started with the formal presentation, I just want to go over a few details about our webinar. Our Compassion in Action webinar series is funded in part by a donation in memory of Julian and Eunice Cohen. We're so appreciative for that. Today's program will be 60 minutes long. The first 45 minutes or thereabouts will consist of a presentation, and that'll be followed by plenty of time for your questions and answers. So please, if you have a question, use that questions pane in your control panel and let us know what you're thinking about. We'd love to hear from you. Today's program is being recorded and will be available on the Schwartz Center's website within the week. I'm going to note also that as an attendee, you're participating in listen-only mode, but you can interact with the speakers by using the questions pane I just mentioned, which should be on your screen. If you have any questions, just type them in and send them to us, and we'll address as many as possible when we get to the end of the presentation. And last but not least, we love your feedback. So as you exit the webinar, you will receive an electronic survey that will ask you to take a minute to complete so we can capture your assessment of today's program. We really appreciate your feedback. And now it is my absolute pleasure to introduce my colleague and our host for today's session. Dr. Beth Lown is an associate professor of medicine at Harvard Medical School, and she's our chief medical officer here at the Schwartz Center for Compassionate Healthcare. Welcome, Beth.
Thank you, Steph, and good afternoon to all of you on the webinar. We thank you for coming and for joining us for this 2019 Compassion in Action webinar series. We're really excited this year that we are going to be hosting our second National Compassion in Action Healthcare Conference that will take place in Boston this September 8th through the 10th. And we are really excited about this conference. We developed it 2 years ago to bring together clinicians, health system leaders, and all who take part in the healthcare endeavor, anyone who is really committed to making compassion a priority in their organizations and communities. So in anticipation of our conference, this year's webinar series will feature speakers whose work has really inspired innovation, leadership, and culture change in the areas that we'll be focusing on during the conference. And these are workforce resilience, well-being, engagement, creating compassionate organizational cultures, compassionate responses to social challenges, communicating with patients, families, and each other, engaging patients, families, and their communities to support health, and finally, compassion science and practice. Today, we are really thrilled to be joined by Dr. Greg McCool, who will discuss the many ways in which patient stories can inform health professional education and really serve as touchstones for practice. He'll also talk about how finding out what matters most to patients can improve the experience and delivery of care in everyday practice. I'm really pleased to introduce him to you now. Greg is a dear and a long-standing friend. He's also an internationally recognized expert in physician, patient, and clinical team communication, interprofessional communication, also with shared decision-making, and generally a person-centered approach to healthcare innovation. Greg is the founder and CEO of Patient Wisdom. He's an executive in residence at Avia and founding director of the Connecticut Institute for Primary Care Innovation. He's also a professor of medicine at the University of Connecticut School of Medicine, following 15 years on faculty at Northwestern University Feinberg School of Medicine. Greg has been widely recognized for his work, and last year he actually received the George Engel Award from the Academy on Communication and Healthcare for outstanding research contributing to the theory, practice, and teaching of effective healthcare communication and related skills. Now, the tools that Greg has developed for his work has always involved really touching back to the heart and the stories of patients and bringing those to us for deeper understanding. And he has explored so many methods of doing so. Today, he's going to show his most recent innovations and the work that he's been doing. So, welcome, Greg.
Thank you very much, Beth. It's great to be with you, and thanks to everybody who's joining us, whether you have a snow day or not. It's great to be with you. And I'll just say I was at the Patient Engagement and Experience Summit at HIMSS yesterday, and in terms of the timeliness of the Compassion in Action conference and theme that Beth spoke about, I mean, the timing is absolutely right. And I can tell you that at this summit I was at yesterday, Adrienne Boise from the Cleveland Clinic started out by asking the audience, what word comes to mind when I say empathy? And the first thing that someone shouted out was finally. Right, and so I think that the planets are aligning for this focus, and the timing is very well placed. So kudos to the Schwartz Center for all the work that they've done to help us get there. Just in terms of the outline for today, my slides, there we go. As Beth mentioned, really want to focus in on how patient stories can help us in terms of both training and practice, and then also take a deeper look at how we can devote attention to finding out what matters to patients and in the real world, and how that can improve both the experience and delivery of care in everyday clinical practice. In terms of what I'd like to highlight here, if I could break this down into sections, I'm not sure whether this is a Super Bowl or a Valentine's theme, but just this idea of X's and O. I want to point out something that I learned early on and how I learned it, and the context here is that patient-centered care sounds pretty simple, but simple things can be hard. Also share with you some of the experience that we had with making patient narrative videos, and I'll explain how and why we did that. Give you a glimpse into the power of patient perspectives when it comes to just defining what health is in the first place, just as an example. And then another example I'd like to share is what we're doing right now to capture patients' stories about themselves, their health, and their care. You can think of this in a technical terms as patient-generated contextual information, and how delivering that to their care teams can change everyday practice and health. And just in terms of disclosures, as Beth mentioned, I am at Patient Wisdom. I am going to show you some screenshots just to illustrate how we're doing this. It's not the only way in the world that it could be done, and just want to make that clear from the outset. So with that, let me give a reality check. And this is what I was getting at in terms of patient-centered care sounds simple. So when I started doing research on doctor-patient communication, it was based on videotapes of real physician-patient encounters. I had about 1,000 from Oxford, England, about 1,000 from Chicago and Vermont. And we were collecting them and looking at what was happening and what wasn't happening and what people thought was happening. And believe me, the perception versus reality frame was very, very interesting there. But I think the bottom line here, in terms of what we're talking about today, is this sense that it sounds really straightforward, right? Just, if you could just respect patients as people and pay attention to patient perspectives and listen, we'd be all set. But I think, in the course of clinical practice where clinicians are getting busier and busier, patients are very busy too, that sometimes what everybody knows what to do and why it's important falls by the wayside. And this screenshot is from one of the early videos. In fact, it's so early, you might notice that there's no computer on the screen and there's actually a folder in the doctor's hands. But what I want to point out is, because this is a video, I know that not only is this doctor, and by the way, let me say, she is one of the best doctors that I know in the world. and she knows what to do, right? But she's not only is her hand on the doorknob at the point she asks, do you have any questions? But she's literally walking out the door. I mean, the door is open at this point. And the patient says, yeah, I don't think so, because the message is, you don't have any questions, right? And so I think the point here that I just want to get across at the outset is that when people are really busy, we have to recognize that even simple things can be hard. And so when we're thinking about solutions, they need to be really easy. And we also need to recognize that it's nobody's fault. This is just real life right now. And I think that, kind of framing it as a reality check to give us a foundation for what we're going to be talking about today is really important. So hope that resonates with the folks on the line here. But let me get into the X's and O part here. So when we did the original study, so this goes back to, we collected these videos in the 1989 frame, and we were doing coding of what was going on. So we were trying to define what encounters looked like by simplifying them in terms of doing content analysis. And this is one of the rules from the code book that I developed. And this is just to show that even, Mr. Communication, right? I have a PhD in communication. I've been doing this for 30 years. But when I was starting out, just to show you how, no one's immune to the importance or sometimes missing the importance of patient perspectives, I wrote this. So if during a particular turn, and a turn means somebody is talking, either the doctor or the patient or a family member, if the doctor or patient is not talking about a problem or a solution, we're not going to code it. Instead, let's just mark an X on that line. Okay, and this goes back to the days of mimeographs, and so thus the purple lines and courier type. But what you can see is at the beginning, and this is from a real encounter that was coded, the first three turns, the patient says something that's not a problem or a solution, we ignore it. The doctor says a response to that, we ignore it. The patient says something else, we ignored it. And then the first problem and a question about the history came up from the doctor. And what hit me after we did this work is we were totally blowing it by ignoring the non-clinical information that was being transmitted between the doctor and patient at the very beginning of the encounter. And that shifted my frame entirely for ever since then. I mean, for from then till now. And this is not just small talk. This is what comes up is highly clinically relevant, non-clinical information. It's not always just at the very beginning of the encounter, but it's really important to recognize that these patient perspectives are everywhere, right? And how do we pay attention to them? How do we make sure that we're making the patient feel heard as we go? So that's the X's and O. And now let's move on to an example of how I took that realization a big step farther in the work. So when I started teaching communication at Northwestern at the medical school, I realized that the medical students, the residents, the attendings, the nurses, what have you, there's no real limit here. By and large, had very little clue what patients are going through in their real lives. And so I thought that would be kind of important in terms of having a more effective encounter. So part of what I did was, in terms of trying to address that issue, was give patients video cameras for as long as they wanted and just ask them to tell me what their lives were like. And we ended up making about 15 documentaries. They're incredibly powerful. And they're still used all over the world, frankly. But 15 documentaries about what it's like to live with diabetes or obesity or different kinds of cancer or Cushing's disease, manic depression, different aspects of the illness experience. And we started using these in the medical education setting, where we would show them to medical students before their communication skills sessions, and we'd show them for 20 to 25 minutes, however long the documentary was. And then we'd have a discussion for 20 or 25 minutes, and then they'd go in and start working with simulated patients, et cetera. And it totally shifted their perspective and became something that was spreading throughout the organization. And we would show them at conferences and get the same sort of response. So when I moved from Northwestern to St. Francis Care in Hartford, Connecticut, about 10 years ago, the first move that I made was to arrange to show these patient narrative videos one a month for the entire first year I was there. So every Thursday, we filled the auditorium with clinical folks, non-clinical folks, people in administration, and we used the same pattern, showed it, and then had a discussion about it. And I can tell you that it absolutely changed the culture. We called it the Patient Perspective Series, and the conversations that we had there in that once a month discussion period in the auditorium, those discussions, you could hear them in the hallways, you could hear them in the clinics, you could hear them in the emergency room. And that is, I think, one example of the power of the patient narratives, of patient stories. And I am going to try to play one here and hope that you can hear it. And I think I will just make sure that you get the volume up.
People in my situation go through a lot, and that's the point that I would like you to take away, to understand. They are not a disease. They are a person with a disease. And that disease permeates their life, has turned their life upside down, has shaken them to their very foundations. And if you do nothing else, remember that when you see them.
Oops.
And they will appreciate it. It can mean the world, because it happens so rarely.
So that last line, if you do nothing else, remember that they are not a disease, they are people with a disease. If you do nothing else, remember that, and it'll mean the world because it happens so rarely. That permeates all of these. I mean, she said it in a capsule that I think is just hits home. But that's the key, and that's how patients feel. And I think that's really important for us to keep in mind as we go forward. So the headline on this particular screen, Sharing Patient Stories Changes Lives, to a person, the people who said they were able to share their story and feel listened to, I mean, it changed their lives. But also, it changes culture. It changes the culture of the people who are taking care of patients, the folks that are on the front line, and it actually changes the culture in organizations that are paying attention to patient perspectives. Schwartz rounds and all of the other great work that's going on out in the firmament, I mean, obviously is in the same vein, but this is an example of how when you focus indirectly on the power of patient stories, the power of patient perspectives, it really moves the needle. Just go on to this one.
I've gone through a lot.
Sorry. Okay. So in terms of shifting gears again, and this is more of a research example, but I want to show you the power of patient perspectives from another framework. So one of the things that I noticed, and I've noticed over and over, is we tend to use terms without being very clear what they mean. And I can't imagine a more fundamental one, given what we're all interested in, than health. So what we did is we did a couple of national surveys to find out what people think health is. So concepts of health in America. And we used two questions, two really simple questions that I learned from reading the research of somebody named Robert Crawford. And we did kind of at scale some of the work he had done on a smaller scale, but I think it's very fundamental and very powerful. And I do believe, that simple things are very, very useful, and these simple questions are terrific. So I'd like to start out by asking you to type into your chat, and I think you'll get better instructions from our moderator here. But type into the chat your response to think about if you're healthy, and type in your response to how do you know? And then we'll talk about that.
Thanks, Greg. This is Stephanie again. Hi, everyone. So this is an invitation to participate in our conversation here and to let us know how you think about your health. So type into the chat, please. Are you healthy, and how do you know? How do you think about your health? What are the terms in which you consider your health? We would love to hear from you via the chat. So if you're raising your hand, if you could go down to your questions or chat pane and fill in your answer there, that would be great. So Greg, we have a couple answers coming in. Thank you, everyone. This is so exciting. So we have a bunch of answers coming in. So I'm going to read them to you, Greg, and then maybe you can share your thoughts. We have one participant saying, no, I'm not healthy. I can't move my body the way I would like to. We have a generally, yes, I'm healthy. I know because I'm not ill. We see, yes, I know my baby and mind. We've got a healthy as a horse. Love that. I am young, so yes, I am healthy. And I'll just pick thank you, everyone. Literally, there are 100 or so answers. But here's, I can mobilize, and with chronic pain, the more steps I take, the better I feel. Yes, I attend preventative care and have conversations with the health team. And then I'll end on this one. I am healthy enough. I know since I can get up and go to work, but I'd like to be more active and happier. So I'm going to pause there. Thank you, everyone, for your comments. We'll have another question, so we'll get to some more of you in a bit. So Greg, what do you think of that?
Yeah, wow. Well, first off, thank you, everybody. These are terrific. And what I want to point out is I think you hit on all four concepts of health that we saw in these national surveys. What we learned is that there are four concepts of health in America. Physical, I'm not sick. My doctor told me I'm healthy. My lab tests are good, that sort of thing. Psychosocial, which I know my mind. So that includes spiritual health. More of what people might think of as wellness at some level. Capacity. In terms of can't move the way I want, being able to do what I want to do, kind of healthy enough. And then control, where I'm healthy because I work out, I eat right, I'm not healthy because I smoke or whatever. So, yes, I get preventative care. Is control. So all of what you've already laid out was borne out in these studies. And what's really interesting is that the control concept actually increased. We did this twice across the country, 7 years apart, and the control concept of health actually increased in the over the years. So this is maybe a cultural thing, maybe a generational thing, but all four are very operational. Now, what I want to point out is the way we define health determines how we address health and healthcare, how we address health policy, how we spend money on health. And so let me show you the results. And I don't want you to try to figure out the Rorschach test here in terms of trying to interpret this, other than to say, if you think that if you're in a mindset, or a provider is in a mindset, clinicians, that health is only physical, it's really important to recognize that across the country, only 43% of Americans think that health is only physical. Okay, so the idea here is that many people hold multiple conceptions of health in their heads. And that is how that determines and influences to a great extent how they deal with it, right? And whether or not they think that their healthcare is dealing with it appropriately. Because if they think that it's missing a big chunk of the way that I think of health, then they're feeling like I'm not getting the care I deserve. So I think this is, I'm really grateful to folks for sharing their views, and hope that what you're seeing here is that all of these physical, psychosocial, capacity, and control are big issues, big things to think about in terms of concepts of health in America, that most people hold more than one of these in their heads. And we want to be thinking about the whole person, the whole patient, when we're thinking not only about patient perspectives, and that came through loud and clear in these videos that I mentioned earlier, but also it comes through every time you talk to patients about what they're looking for and what does it mean to take care of the whole person. So just another example there. And we're going to shift gears again here. I'm trying to do like a little bit of a whirlwind tour on the power of patient perspectives. So here's the next question for you. And if you could use the same mechanism, and Stephanie will remind you. But this is something that I ask people in many venues. And most recently, I did a presentation at the IHI National Forum, and asked a room full of people. When you hear people say that they love their doctor or nurse or clinician writ large, or they don't, in whatever terms they say that, what do they say? What are they looking for? Okay, or what do you say? So if Stephanie, if you can just sort of remind folks, and then we'll kind of hear what people are saying.
Yeah, absolutely. Actually, we've got some really quick learners here because we're already seeing the answers come on in. I love that question, Greg. Thanks. So if you haven't already answered, think about that. When you hear people say they love their clinician or they don't, what are they looking at? What are they thinking about? Okay, so I'm going to read a sample of our answers here. Here's one: because she listens to me and understands me. Here's one: I love because they are genuine. Mm-hmm. I'll stick with some positive for now, and then we'll go to the negative. They take time with us and listen to us. They listen to me. So there's a lot of listening. I'm seeing a lot of listening coming through. Someone who listens and is compassionate, the person who listened to them, that their doctor listens. So we see a lot of listening. Here's another one. They refer to character traits that are not related to quality indicators. So there's one to think about. And then let's look. If people say they don't love their clinician, what are they saying? And we've only got a few of these, relatively fewer. So we see poor eye contact, focusing on the computer. Any other negative ones here? Does anyone else have thoughts on when someone says they don't listen? And someone alludes to the fact they don't usually mean clinical skills like IV starts, but compassion and listening. So whichever way they're going, it's really about who they are and not what they're doing. And what else? They were so rude is something we hear. I'm not going back to someone who doesn't respect me, who doesn't let me talk and isn't even in the room for 2 minutes, someone who interrupts. I could go on for so long. You all are amazing. Thank you so much. And I'm going to have to hand it back to Greg. And one more, before I do, one quick comment. If you've raised your hand, unfortunately, all of our attendees are in listen-only mode. So if you've raised your hand and you'd like to comment to me or to Beth or to Greg, please use the questions pane again, and we'll look for your questions, and we'll be happy to share your comments during the Q&A. So back to you, Greg.
Well, thank you again. I mean, what a great group of really engaged folks. And I have to tell you that this is what we see pretty much every time I ask this question. And I want to reinforce that Stephanie said, listening plus or times 100 as we go here. But, and obviously all of these things cut both ways, right? So it sort of listens or doesn't, understands me or doesn't, that kind of thing. But, you know, normally we'll let this go for a while and then step back from, you know, the wall we've just filled up with what people are saying, or the chat bots. And thank you, Stephanie, for doing such a great job of summarizing all of this. And kind of step back and look at it and say, what do you notice? And rather than doing another polling question, I'll guess what you're noticing is it's all communication, right? So people are not judging or saying, you know, I don't want to kind of overdo the word judging here, but are not thinking about whether or not their clinician is great or not based on where they went to medical school or PA school or nursing school, or how much, you know, technical skill they have. All of that is basically assumed. And what they are really looking at, and all they can, you know, kind of hang on to here is the communication, the relationship, right? And that relationship is to a large degree determined by the extent to which the person that they're working with is paying attention to them as people, paying attention to their perspectives. So think about listening, understanding, even time is a communication, you know, aspect. So all of this, and I loved, you know, to hear, you know, compassionate and focusing on character traits that aren't directly related to quality indicators and these other things on the flip side as well, because they really round this point out. And again, this is just at the most basic level. If we can just get focused on, you know, at root what matters, and what matters is remembering that we're dealing with human beings on both sides of the stethoscope, right? And if we can keep that in mind as we're going, that is the essence of compassionate care for both patients and clinicians and clinical teams. So thank you all very, very much. And we're going to shift gears again into this next screen here. As you know, as somebody who's been focused on communication in healthcare for quite a long time now, we know that there's excellent research literature supporting that the concept, kind of the common sense concept, that if we can improve communication between providers and patients, then we can generate very tangible outcomes. And I've put them in these three different buckets. Patients and families feel better, clinical encounters work better, and health organizations do better. And often that's, you know, what the CFOs might be looking at, okay? But, you know, think about it in terms of patient experience scores, health outcomes, you know, in terms of patients and families feeling better. Provider satisfaction, we all know that burnout is the next big problem to solve in healthcare. If you have better communication with patients, it's a good thing in terms of the way that the clinical teams feel. You also end up getting better adherence and all of the good things that come from there, linked to the same improved communication. And then in terms of these kind of purple circles, they're more of the, you know, kind of hard green dollar ROI, if you will. But all of this is borne out by the research literature, and it is, you know, you can consider this as a subset of the, you know, the value of improving communication. And by and large, again, improving communication means you're paying attention to the patient as a person. You're paying attention to the patient perspective. So it's another kind of power here. And what I'd like to lay out is the sense that, you know, why doesn't this happen all the time, right? And I think what has happened is, you know, the world has gotten so busy and healthcare has gotten, so overwhelming to a large extent, that we kind of forget the focus on what matters. And, I've got 3 little snippets here to just kind of prove this out from different perspectives. So the one on the top, patient engagement strategies lack patient voice and consumer input. The idea here, this is the organizational perspective. You have almost all health organizations saying, we value patient engagement. We really do. But most of them don't really pay attention to what the patients are saying when they're designing these efforts. So, we're not there yet, okay? Really just scratching the surface. The Harvard Business Review article came out a little over a year ago. This is by a physician at the Henry Ford Health System and a colleague, talking about the fact that, the key resource is being systematically depleted, and that's the time and capacity to listen, going right back to the main comment there, to hear their stories and learn not just what's the matter with them, but also what matters to them. And then it's this tweet at the bottom. I just love this because you can hear Erin Moore's tone of voice, right? And she has a child with a chronic illness, and it would be relevant to me if you join me what I'm doing instead of trying to engage me in what you're doing. And I think that's exactly how patients feel. I think that many patient engagement strategies, many patient engagement tools are very well-intentioned ways to tell patients what to do. That's not real patient engagement. Real patient engagement is about finding out what do they need to do, what do they want to do, what's getting in their way of doing it, and then helping them take a more active role in maintaining or improving their health. So again, a very significant shift in perspective. And so, well, who cares? Why should we care? We care because it's better care if you're really paying attention to patient perspectives. In only, this study is a little bit dated now, but I don't think the results would be much different these days. Only 11% of visits, in only 11% of visits, did clinicians have a complete picture of their patient's agenda. Okay, and if you don't know what is on your patient's mind, that patient may or may not be getting the kind of care that they need and deserve. And then in terms of health outcomes, there's almost a 4-fold increase or improvement in health outcomes if you have that contextual data about patients. So again, this is that kind of highly clinically relevant non-clinical information, their goals, their barriers, how their health affects their lives, what are the biggest problems, that sort of thing. And so what we're seeing here is a picture coming together of if we could only find out what matters to patients and make it easy to kind of make that a reliable part of the encounter, or reliably noticed and addressed part of the encounter, we can probably do better. And so I think that, one thing to think about is the opportunity to basically acknowledge that, we have no idea what patients are going through in their real lives, and most of their real lives happen outside of the care setting. And so how do we make it, again, easy and systematic to find out what matters to them, what they see as important. Also to acknowledge that providers are drowning. They're busier than ever. It's harder for them to connect with their patients. That doesn't make them feel any better. And, they need a very quick, reliable way to learn about the whole patient in their workflow. If it's an extra added attraction, it's just not going to happen. They have too much to do already. And then, as I mentioned, most organizations really just still scratching the surface about in terms of patient engagement, because they're focusing on it from their terms, not on the patient's terms. And so how do you flip that script, so to speak? And instead of having the organizations reach out to patients and say, hey, what do you think of my idea? Having them reach out to patients and saying, hey, what do you think, period? What do you need? What are you trying to accomplish? So very, very different way of thinking. And I just want to give you an example here of how we're approaching this now and what we're doing at Patient Wisdom. So we reach out to patients ahead of clinical encounters. And we ask them to share. It's a mobile responsive site. You can do it on your phone or anything up from that. and a mobile responsive site, we ask them to share what we call stories about themselves, their health, and their care. If they do the whole thing in one sitting, it takes about 10 minutes. And then at the visit, or just ahead of a visit, any member of their care team who has access, to their electronic health record is able to view this one-screen summary of who the patient is as a person, what's important to him or her, and where the patient is on different style and preference meters. So they can look at this for 15 seconds, go in, do a better job, and save time. After the visit, if the organization wants us to, we can ping the patients, ask them to gauge their provider's communication or ideas for improvement, and then across visits we're able to show population view. And I just want to let me just see, these are accelerating, lay out that the results are very, very positive. And I won't go into great detail here, but what we're seeing is that patients are saying that improves communication. 90% of patients improves communication with the providers that use it. That's what we're looking for. Again, if you think back to that communication slide. And then the idea here, and this is where I really want to close before we get into the Q&A, is that we're really trying to move from where things feel like health transactions. I think this is a great source of dissatisfaction for both patients and providers, to where they become more healing relationships, and again, for both patients and providers. And if we can do that, if we can bring the patient perspective to the fore in the context of everyday clinical practice, I think that we are going to see a real transformation as we go. And finally, this is the last slide here. You see a recurring theme about listening, not only in terms of what what folks on the line here were saying earlier, but also what people ranging from Don Berwick to Sir William Osler were talking about. And this quote on the kind of the purple bubble on the left-hand side, if patient engagement is the blockbuster drug of the century, and I think it is, I think that's a reasonable way to construe it, we need to be really clear about what patient engagement is, and we need to do a far better job of focusing on it. And I think if we can do that, we are going to change the frame and change the experience and delivery of healthcare for both patients and providers. And one way that I try to think about this and encapsulate this is that we're talking about meetings between experts, right? That clinicians are experts on clinical medicine, no question. Patients are experts on their lives. And if they're not taking advantage of each other's expertise, then we're really missing the boat and missing a great opportunity to have the best kind of healthcare that we possibly can. So thank you all very much.
Well, thank you so much, Greg, for this presentation. It's really been so helpful and so interesting. And we do have some questions from our participants to pose to you. So let me share some of these with you, okay?
Sure.
The first question that we have here is some concern about whether or not there's really anything that we can do to help healthcare professionals communicate better with their patients without unduly burdening them. And I know that that is really your goal with what you're trying to do here with this application and putting this right into the workflow of the medical record. I know you have some data on what providers are saying. You want to just share a little bit of that about how that's working for them?
Sure. Yeah, and it's the fundamental question. It's right on. We knew, and this is, I guess if I can rewind a tiny bit, and I will keep this short, Beth, but when I started working, I was at Northwestern for 15 years, and we were doing all sorts of research and grants and interventions to try to improve communication. And when I moved to, and it was great, when I moved to St. Francis, it felt like moving into a crucible in terms of a very different, very real world environment where you had very busy people in a very busy place, very thin margins. And the sense was, if the value wasn't right in front of people's nose every day, it just, things weren't going to go anywhere. And I'm thinking about innovations writ large. And so one of the things that, I tried to think about from the get-go when we were creating, what we're doing now with Patient Wisdom, was how do we make it just super simple? So what we're seeing is that by making it an easy view, they don't have to go out to something else. It's in the EHR. And it either auto launches, so nobody has to do you don't have to click on anything, or it's one click to get to it. That's kind of solved that problem. In terms of how people are using it, that's the best data really of all, because what the providers are telling us is not only are they learning what's important to their patients, but it's changing care. And this is even, I think it's important to say, even primary care providers who have long-standing relationships with their patients have been blown away by, they never told me this. I had no idea, so I think that's really critical.
That's interesting. Yeah, and there's some data too that some people are more likely to enter into a computer or into a survey that's online information that they won't say out loud. So that's actually really pretty interesting. I don't know if you've used it to uncover sort of these sensitive issues, perhaps things like substance use or anything else, intimate partner violence and things like that are sometimes really hard to get at, even if you have a long-standing relationship.
Yes, indeed. It is coming through, and we're seeing all of these things that whether people they haven't mentioned it because maybe they were embarrassed, or maybe they were never asked, or they never felt safe talking about it. I mean, we are seeing things ranging from anxiety to to I don't feel safe in my home, to other issues. So yes, absolutely, Beth, you're right on.
Greg, is there a way for people to flag that? Because I can imagine somebody might enter something sensitive, but if a provider is like really super busy and can't get to it or doesn't see it, they might not respond or notice it in time.
Yeah.
Is there a way to flag something like that?
Yeah, we actually felt morally and ethically responsible to do that. So sure. We are running content analysis. I mean, everything's HIPAA compliant, so we can't see, who the patient, the coders can't see who the patient is. But we've created these alerts where we've got an alert called a danger alert. And if somebody says they're thinking about harming themselves or someone else, or some of these other things that we've talked about, we will flag it. We kind of pre-wire a protocol with the organizations we're working with, so we don't wait for somebody to see it. And we've been able, so far, we've been able to get the information to the teams before the patient even showed up. So they were able to have a different kind of encounter, which is,
super important. Yeah. We've got a lot of questions here about communicating across cultures with and without interpreters and so forth. And I'm just wondering about that, and how do you really hear what's important, especially if you're having to use interpreters, or I'm not quite sure how this works in different languages, or how do you do that? How do you engage patients across culture and language?
Well, I think there are two different answers to that question, or two different levels to the answer. The first is, in terms of what we're doing, we have it in different languages. So we go with what the patient wants. Their preferred reading language is what they're using it for. But I think more broadly, and maybe more importantly, is there's in the old days, and I don't think this is gone. It would be like anybody speak Lithuanian, I mean, whatever, without getting the professional, interpreters there or using an interpreter line. And I think it's really important to try to use the professional services that are available whenever they are available. But I would say that how do you get underneath that a little bit? It's also to watch the patient, right? And to hear even if you don't understand the language, you're hearing their tone of voice, you're watching their face, you're watching, right? And they're so expressive, everybody is when they're describing what's important to them and what they're going through and what they're up against, that you can glean a lot from that rounds out what may feel like a more sterile game of telephone, if you will, through the interpreter, no matter how good the interpreter is. And the professional interpreters are awesome. But I think it's really important. I would just suggest that people are really watching the patient too, not watching the interpreter.
Yeah, and talking directly with making eye contact to the patient and not talking to the interpreter. Some just general guidelines there, but it's hard. The other question that came into our pain here is our chat pain here is about incorporating efforts to improve health literacy into patient engagement, particularly for patients who cannot read. That could be really difficult. So how do you think about that or approach that when trying to really engage with patients so that you can understand what's important to them?
Yeah, these are fantastic questions. We've been really interested, I mean, over the years, whether at Northwestern or afterward, in how do we help one understand health literacy, but also address literacy. And so, a big part of it is making sure that if there are materials that in whatever form they're in, print or digital, that they are clear and at as if you can get it at a fourth grade reading level, and most things you can, it's worth doing. But I think also it's recognizing that if a patient has any kind of support system, I guess let me rewind that a tiny bit, is determining if a patient has any kind of support system in terms of companions or caregivers, whether that's parents or adult children, who can help them and really try to round out that understanding. And that's, so there's like, just literally readability kind of literacy, but then there's also health literacy, and healthcare is just obtuse for many people. And so remembering the importance of just, boiling it down and not getting caught up in the jargon. And again, whether that's face-to-face or telemedicine or materials that are being handed out, the patient education materials can be quite daunting unless they're paying equal attention.
Yeah, they're so crazy and complex. I think there was a survey that just was reported about the majority of people not really being able to administer a dose of medication properly when trying to just read it from the label. Yeah. It's complicated, and literacy, you're right, it's not just about reading, it's understanding, synthesizing, trying to figure out what that means to you, and then being able to apply information. Yeah. So we got tons more yeah. Oh, I'm sorry. Go ahead.
I was just going to say, and that doesn't even touch numeracy, right? So.
Right.
Yeah.
Another whole issue. So there's so many questions here. This is really fantastic. People are curious about how you engage with patients in building this patient wisdom, and some of the other work that you've done as well. But in particular, somebody was curious about patient engagement in your work with this example in mind.
So we do a ton of co-design with patients. One of the things that I I say pretty often is the one way to make sure that things are going to fail is to get a bunch of people like us around a conference room table and deciding what patients know. So we started by talking to patients, and we built something with patients that they said would solve a problem that they need to solve. So we kind of always, I guess, two things. We always start with the problem that, what's the problem to solve in all of our discussions. And we always try to make sure that patients are weighing in, and not just like, hey, what do you think of this? But, what are you trying to achieve, and what are your ideas for trying to get there? I can give you one example that is, again, kind of going beyond, and not going beyond patient wisdom, but when you mentioned the work that I'd done with the Connecticut Institute for Primary Care Innovation, one of the things that we created there was a group of what we called patient architects. And I think this is another great example of the power of patient perspectives. These are people who, got their healthcare in Hartford, and we brought them together. We kind of gave them a little, we got to know them, and then gave them a little session on, basically how we look at processes and outcomes. And then ask them to go into the clinic that they go to, and then one that they don't go to, and tell us what's going on, what they see and what needs to be fixed. And we learned so much from that process. It was incredible. And, ranging from, the clinic I go to, has this like bulletproof glass, at the reception desk. Yes. And that's not a very welcoming feeling, right? And what was wild about it is the other clinic was thinking about putting that in, and they actually, didn't, because of what the patients were saying. But it ranged all the way to, we rewrote the mission statement for the primary care clinics based on what patients said. We asked patients, why does this place exist for you, right? And we ended up rewriting the entire mission statement. So it was something that not only felt right to patients and true to patients, but it was something that the people that are taking care of patients could actually understand. So it's on the wall everywhere now. It's like this real stuff, and it matters.
Yeah. Oh gosh, I have so many more questions, but I'm being told that I'm going to have to wrap up pretty soon. I just want to make the point, there were some people who were asking about, patient family advisory councils, and some of the points that you just made in terms of the primary care clinic are definitely applicable to helping PFACs think about how to really work with the patients on their PFAC to get some of these perspectives into the patient engagement initiatives.
Yeah,
so unfortunately, there's so many more questions.
Yeah, I know we've got to jump. Just if I can make one final comment, because you raised the PFACs. Yeah. It's a great concept, and I would just highly recommend that folks that are running them or facilitating them are doing everything they can to try to broaden it beyond what do you think of this, and more about what do you so
absolutely, that's such an important point, letting them guide the way. All right, well, and we really have to wrap up, so I'm going to turn the program back over to Stephanie to wrap the program up. And thanks again, Greg. It's just been a wonderful experience. And judging from all the questions and the input and the excitement here on this chat pane, I think people really enjoyed it. So, Steph, your turn. Take it away.
Thanks so much, Beth, and thanks, Greg. Way to navigate those millions of questions that came in. And thank you, everyone, for your really wonderful engagement in today's conversation. There's my dog ready for the webinar to end. Excuse us. So I just want to thank everyone. We hope you enjoyed this first in our series of Compassion in Action webinars for 2019. Again, these webinars this year are inspired by our upcoming Compassion in Action conference. So if you'd like more information about that, you can visit the Schwartz Center's website or look at compassioninactionconference.org. And we really hope you'll join us in September. Right around the corner. Until then, we know how busy you all are, but we would appreciate you taking a minute to fill out our survey on your way out. We'd love your feedback on today's webinar, and thank you everyone so much for joining us. Have a fantastic day.
Thank you.